All right, I think we're good to go ahead and get started. So thanks everybody for joining us. Welcome to our first ever Vail-Summit Orthopaedics and VSON Alpine joint webinar. We're really excited to be hosting this. Hopefully we have a good amount of people coming from both Eagle and Summit, and then our Gunnison and Telluride areas as well. Hope everybody enjoys the talk tonight. So I would like to introduce myself first. I'm Rachel. I'm the Director of Marketing. I'm going to be in the background most of the time, but I'm going to be helping to manage questions as well as any follow-up emails or inquiries that come in after this event. So with that said, we will be doing a Q&A session throughout and towards the end of this event. So you can feel free to submit your questions in the chat here, or in the chat, in the Q&A section at the bottom. You can submit your questions there as well. Whatever works best for you, feel free to submit them. We're gonna try and get you as many questions as possible with the time we have. Probably gonna spend about 20 to 30 minutes on questions. And with that said, I wanna introduce Dr. Nathan Cafferky, who is our total joints specialist at Vail-Summit Orthopaedics and Neurosurgery, who is mainly in our main practices. And then I want to introduce Dr. Gloria Beim, who is an orthopedics and sports medicine specialist. She is the lead surgeon at VSON Alpine, and she founded that clinic back in 1999. So we're really excited to have her on board and to be teaming up with her and all the great things she has to offer. So with that said, I'm going to go ahead and let the docs take it away.
Thank you, Rachel. And it's good to see everyone tonight. I'm Dr. Nathan Cafferky, and with me is Dr. Gloria Beim. I want to let Dr. Beim go over her introduction slide here, as she is probably one of the most impressive people I've ever met. And working with her is very exciting. And anyway, I'll let her take it over from here.
Thank you, Dr. Cafferky. Hello, everybody. It's really great to have you here, and we appreciate it. Hopefully you'll learn something really exciting, and I know you will, about total joint replacement from Dr. Cafferky, who is amazing. He actually did my total knee about 6 weeks ago, and I'm doing awesome. But I've been here since '96. I trained back east at Columbia for 5 years, and then I did a sports medicine fellowship, shoulder and knee fellowship in Pittsburgh. And I got here in '96, and in '99, I opened up Alpine Orthopaedics, and I've been serving Gunnison, Crested Butte, and Telluride since then. And I just have a wonderful population of patients from all those areas. And we also have patients traveling from all over the country, actually. So it's wonderful. I've been alone for a long time, and to be a partner with such an esteemed group of orthopedic surgeons as from Vail-Summit Orthopaedics and Neurosurgery is amazing. It's a dream come true. And we're going to have so much to offer this community, so much more than we could before when I was alone. It's just wonderful. And I've been taking care of WCU, or Western Colorado University, as it's called now, since I got here 25 years ago. And I love taking care of athletes at all levels, from elementary school to college and professional and Olympic sports. I've been honored to have attended 6 Olympic or Paralympic Games. I've been to both, and I'm going to be in my 7th in Beijing this March, which is very exciting. I've learned so much from traveling all over the world with teams and athletes, and I try to bring it all back here and help everybody, whether they're an athlete or not, to make their lives better and their athletics better. And that's my goal. That's my vision. So again, I'm thrilled to have the partnership with Vail-Summit Orthopaedics and Neurosurgery, and particularly Dr. Cafferky. And now it's your turn, Dr. Cafferky.
Thanks, Dr. Beim. It's a pleasure to work with you as well. So I also want to introduce myself. Some of you on this call may already know both of us, but for those of you that don't, we want to make sure that we give everyone an opportunity to ask questions throughout this talk, and specifically at the end. But again, I'm Dr. Nathan Cafferky. This is my resume here, basically, and definitely not as impressive as Dr. Beim's. But with that being said, I'm a board certified fellowship trained total joint surgeon at Vail-Summit Orthopaedics here in Vail and Summit County. And it's with a great honor that we have started to collaborate with Dr. Beim and Alpine Orthopaedics in Gunnison and Crested Butte and Telluride in order to bring additional service lines to your community. And overall, my vision for our total joints practice as we continue to expand is to improve patient experience and outcomes through individualized patient care and technology, meaning we are using cutting edge protocols, cutting edge techniques, and cutting edge technologies in order to get patients back on the road to recovery and getting them back out there so that you can enjoy your activities that you love. So, this conversation with Dr. Beim started well over a year ago. And as you can see here, we finally were able to, finalize the merger back, I think, the end of August, early September of 2021. And as you can see, Alpine Orthopaedics has a longstanding excellent reputation. So does Vail-Summit Orthopaedics. And now combine those together, we now have Vail-Summit Orthopaedics Alpine in Gunnison, which is a wonderful opportunity. And as you can see here, the new service lines that are now available to our patients in the Gunnison Valley, Crested Butte, and in Telluride includes all of the sports medicine that you've had access to before with Dr. Beim's talents. Including both operative and non-operative care. Keep in mind that a lot of the non-operative care available to you for any of these specialties are available to you at VSON Alpine. We now can offer total joint replacements, both primary, complex, and revision surgeries. We'll kind of go into that here in a little bit more detail in just a minute. We also have Dr. Braxton, our neurosurgery partner, that does a lot of minimally invasive spine. We have interventional pain medicine with Dr. Nurki and Dr. Rob that do everything from injections with steroids to biologics to ultrasound treatments and are a huge asset to our patients. Hand and wrist, shoulder and elbow with Dr. Dorff and Dr. Joseph and Dr. Cunningham, Dr. Sider, Dr. Starrett, foot and ankle with Dr. Elton, minimally invasive surgeries. All of us perform minimally invasive surgeries. We do joint preservation with our arthroscopic practices, the scopes that we do in the shoulder and the hip and the knee, and we cover orthopedic trauma. And then again, the new locations now that we've merged include Gunnison, Crested Butte, Telluride, Buena Vista with our outreach clinic there, Frisco and Summit County from Breckenridge to Silverthorne and everything between, Vail, Edwards, Eagle, and Grand County with our new expansion into Granby as well. So as you can see, we're a growing practice and we're excited to take care of all of our patients. And one thing we want to mention is that with this merger, we now have access to our Vail-Summit Orthopaedics Foundation in the Gunnison Valley. And this allows us to do cutting edge research, myself included with a number of my other partners. We are publishing multiple publications per year, from basic science research to outcome-based research to case reports to things that are helping move medicine forward, making surgery and orthopedics better for you. We're working with our educational platform. We have athletic training fellows that work with us throughout the year. They learn how to be first assistants in the operating room. They learn to cover the athletic fields at the high school and the college level. And so they're working closely in your communities with you. Development, myself included, and a number of other surgeons, we're working closely with industry to help develop new technologies to benefit our patients. And we're giving back to our communities by putting additional resources for you into your community. And other thing to keep in mind is with Dr. Beim's, Olympic experience, all of us are U.S. ski team physicians. And so we bring that expertise to your communities as well. And I couldn't give this talk without giving a shout out to John Policandriotis. He's our CEO, our Chief Executive Officer at Vail-Summit Orthopaedics and Alpine now. And he's really been a visionary for our practice. And with all of our talented partners, we've had this growth vision for quite some time in order to, again, provide excellent orthopedic care to our mountain communities to keep people active. And with John's help, Vail-Summit Orthopaedics was actually voted to be the 2020 Practice of the Year among the American Association of Orthopedic Executives. So that's a high honor. That includes all orthopedic practices from private practice to hospital-based practices from all over the country. So that's a huge honor that John's been able to achieve for us. So in order to kind of understand what we can bring to the table in Gunnison, I want to go through today's talk with you. And we're going to talk briefly about what adult reconstruction is. Oftentimes I say that to people and they don't know what I'm talking about. So I want to make sure we kind of define that. What arthritis is. There are three major categories of arthritis, and we'll go through those together. We'll talk about a brief history of adult reconstruction, kind of where we started, a century ago and where we are today and how we got here and where we're going. Treatment options for arthritis, both operative and non-operative treatments. And we'll discuss some newer advances in surgical treatment and techniques. We're going to review a couple cases. And we're going to conclude by bringing, discussing how we're bringing total joint replacement surgery to Gunnison, specifically outpatient total joints. So adult reconstruction is really an orthopedic subspecialty that focuses on the surgical treatment of painful arthritic hip and knee conditions. It's also known as total joint replacement surgery. And arthritis is really a generic term that describes the process in which the normal joint cartilage breaks down. So if you think about a healthy joint is like a nice Zamboni ice skating rink. It's really nice. It's easy to skate on. It's very smooth. But after 3 periods of playing hockey on the ice, it gets really chewed up. And that's what happens is arthritis goes from this nice, smooth hockey rink. It gets kind of destroyed and rutted out. And it's not very fun. And it gets very painful. And that's because the cartilage is breaking down. It's forming all these ruts and potholes and you name it. And so arthritis is really the process in which cartilage breaks down, resulting in a lot of inflammation, a lot of pain, a lot of swelling, a lot of stiffness, a lot of mechanical symptoms that we describe as clicking and popping, crunching, snapping, those kind of things. And so there are 3 major causes or 3 major categories of arthritis, from an inflammatory arthropathy, which is basically where you can thank your parents for this, typically as you get rheumatoid arthritis or psoriatic arthritis. That's more of a genetic component, but there are some environmental factors as well. The wear and tear arthritis is the most common form of arthritis we see here in the mountains because we're such an active lifestyle. Now, I kind of joke around that we have 2 choices in life. We can sit on the couch and, develop diabetes, or we can be outside exercising and develop arthritis. So we get to pick our poison, so to speak. And most of us living in the mountains enjoy being active, but unfortunately can develop arthritis over time. We call that osteoarthritis. And then there's post-traumatic arthritis. Well, sometimes we're dealt a specific hand that we have to play in life. And, when you have a bad trauma, a bad tibial plateau fracture, a bad, ankle fracture, hip fracture, whatever that is, that can lead to arthritis over time. And it's, that's why we never say it's your last ski run of the day. We always say it's the second to last as you're heading down the mountain. So again, this is kind of a picture of what hip arthritis looks like. So if you look at the left side of your screen, you see a healthy appearing hip joint, nice round femoral head, nice congruent socket, the acetabulum, and nice smooth looking cartilage. As that hip joint starts to break down, we see it start to look pretty rough. It starts to become deformed. We have a lot of osteophytes, those bone spurs that people typically have pain because of. And the cartilage is just broken down and you're starting to rub bone on bone. And that's causing a lot of pain and inflammation and mechanical symptoms. With the knee joint, it's a very similar process. On the left side of the screen, we see a healthy appearing knee joint with healthy cartilage, healthy soft tissue structures. And over time, with any 3 of those prior categories, we can develop these bone spurs, potholes, cartilage debris, damage, and again, lots of pain, stiffness, irritation, inflammation, and that can be very, very uncomfortable. So let's say you have joint pain. Well, what do you do now? Your joints have been hurting for a while. You haven't really had an evaluation, but it's just kind of becoming more annoying. Well, the good news is you can come in now and get a consultation with Vail-Summit Orthopaedics, both at our Alpine clinic or in our Summit and Eagle County clinics, in order to better kind of understand where we're at. And there are a couple different treatment options, and there's kind of this global option, 2 major global options with arthritis. There's the non-operative treatment, which includes physical therapy and injections and weight loss and anti-inflammatories and activity modifications. And then there's the surgical management, which again, we'll get into in a little bit. But unfortunately, once we develop arthritis, there's no medical cure for arthritis. Okay, so keep that in mind, but there are ways that we can help you avoid surgery. So osteoarthritis and post-traumatic arthritis, the non-operative treatments consist of low impact aerobic exercises such as swimming, biking, elliptical machines. This maintains a cardiopulmonary health, i.e., example for your lungs and your heart. It helps decrease the painful forces felt across the hip and knee joint, and it keeps your joints moving. Remember, arthritis, once it happens, it's you kind of want to use it or lose it, so to speak. So most people with arthritis, they have this kind of startup pain. It really doesn't feel good after they sit for a while. They get up and walk, and you're like, oh, I got to work this out. But once they start moving, it actually starts to feel better. So with arthritis, we want you to move. We want you to get up and walk. We want you to focus on those low impact exercises. The other thing that can be very helpful is the over-the-counter anti-inflammatories, such as non-steroidal anti-inflammatories, such as Aleve, Advil, ibuprofen, naproxen, Celebrex. These help fight the underlying joint inflammation. So they are pain control, but they're also controlling the pain and swelling, and that's the fundamental mechanism of anti-inflammatories. Some people come in asking for narcotics, and I understand that patients are in a lot of pain, but narcotics really typically just gets us into more trouble. And so we reserve narcotics for after surgery. Narcotics don't treat the inflammation or arthritis, they just mask it. And so a lot of the time with this new concern about narcotic addiction, we don't want to put people on narcotics preoperatively. We want to use them for short courses postoperatively so that we can get you off of them in a matter of just a few weeks after your surgery. So osteoarthritis, again, post-traumatic arthritis, we can use intra-articular joint injections from steroids. That's typically our first-line treatment. A lot of people ask about steroids. Well, doesn't that cause joint damage? Well, at the end of the day, we do know that as long as you get these injections spaced out at least 3 months apart, the risk of progressive joint damage is quite low. If you're getting a lot of injections repetitively into the same joint, back to back to back to back to back, you can cause advancement of your arthritis. So we do recommend for steroid injections no more than probably 4 injections per year, or 1 injection every 3 months. With viscose supplementation, which everyone refers to as the rooster juice, these are really kind of like, it's like WD-40. You're kind of oiling up the hinge, so to speak. And this is more of a lubricant, and you're injecting this into the joint. This has been brought into question with a lot of high-level evidence research. Patients do respond to it, but because there's a mixed bag of results, we don't use this as a first-line treatment. We reserve this for patients who may need to trial alternative injections if they're not responding to steroid. You want to maintain a healthy diet. Again, you want to maintain the appropriate nutrition to keep your body mass index in check and keep you active. And the other thing is maintain a healthy weight. Body mass index, as we know, is our height versus our weight. And with that being said, the heavier we are, the more painful forces we feel across the hip and the knee. And so sometimes I know that this is a very emotional conversation. And as we talk about this, it can be very frustrating for patients. But keep in mind that the good news is that for every pound we carry on our body, 3 times that amount of force is felt across the hip with walking, and 4 times that amount of force is felt across the knee with walking. So for a 200-pound man like myself, if I were to lose 5 pounds, my hip would feel like I lost 15 pounds and my knee would feel like I lost 20. So you don't have to lose tons of weight, but just losing a couple pounds can make a world of difference for your joints. So once we've trialed and failed the non-operative treatments, which I always recommend patients do before they commit to surgery, once we've trialed and failed those treatments, we can move on to the surgical management. The good news is that the operative treatments for painful arthritic joints, both hip and knee, have advanced tremendously over the years. So in order to understand where we are today with our total joints and where we're planning on going with total joint replacement surgery, we actually need to quickly review where we came from. It wasn't that long ago that patients with bad knee and hip arthritis were really kind of condemned to a lifetime of disability. 100 years ago, minimal treatments existed for arthritis. Patients were left disabled. And it really wasn't until about the late 1800s where orthopedic surgeons, and actually back then they were just surgeons. Orthopedic surgery as a professional organization didn't exist until after this time. And so surgeons back in 1891 and 1860s were experimenting with artificial joints. In Germany, Dr. Gluck or Professor Gluck was working with ivory. In France in the 1860s, they were working with soft tissue interposition, basically taking fat and putting it in there. In the USA in 1925, Dr. Smith Peterson started working with utilizing glass to replace hips. Interestingly enough, the hip approach that we use today for the anterior hip, which we'll get into, is the Smith-Peterson approach. So the anterior approach, the actual incision we used, was developed back in 1925, which is pretty incredible. Back in Sweden in 1947, they started working with artificial knee replacements, but they were more of a hinge, like what you would see on your door. And those are okay, but still had issues. So moving on, it wasn't until probably the 1960s and 1970s that we started to see the modern day total joint show up. So in England in the 1960s, Dr. Sir John Charnley developed a low friction hip arthroplasty, and he's considered the father of the modern day total hip. That's where he took a metal femoral head and articulated that on a plastic socket. And that's actually what we use today. But kind of generations of advancement have occurred. In the USA, 1973, Dr. Insull came up with a total condylar prosthesis, and he is considered the father of the modern day total knee. And again, all these fundamentals and teachings and principles are what we're building our foundations off of. It wasn't until really I showed up in Vail in 2015 that we started to bring a lot of newer technologies. I finished my fellowship in 2015 and came up to Vail right after that. And we brought new technologies to the mountains with minimally invasive direct anterior hip replacements and robotic assisted and customized total knee replacements. And we started working with our anesthesia colleagues and our physical therapy colleagues to really focus on rapid recovery techniques. And we started to evolve our program to incorporate outpatient total joint surgeries very early on, actually. And so really started working again with our outpatient total joints program here in Vail, seriously around 2017, I would say. And that allowed us to develop some protocols early on and that are now nationally recognized. And this allowed us to work on our educational platform with working with our patients, our patients' families, their friends, your primary care doctor, your local ER doctors, so that people know that this is how we are taking care of our patients now. Our anesthesia teams are incredible, and they're on board with, short-acting spinal anesthetics and peripheral nerve blocks to keep you comfortable so you can go home very quickly. Rapid recovery physical therapy. We do know that with all of our research over the last 100 years that the patients who get up and walk the fastest are going to do the best. And so our goal is to get you up walking with physical therapy that afternoon after physical therapy. We want you to start walking really within about 2 to 4 hours. Basically, as soon as the spinal has worn off, we want you up walking. An outpatient post-operative physical therapy starts about a day or two later. Pain control. Remember, when I was a kid, my grandmother had both of her knees replaced, and she probably spent a month in the hospital. That's what it seemed like to me when I was 12 years old. It's incredible to see that over my training, we used to keep patients 10 years ago in the hospital for 2, 3, 5 days sometimes before they would go home. And why we did that was really because of pain control and PT. As we figured this out, we've been able to make sure that all the medications you historically would get in the hospital, we're actually going to send home with you now. And so that allows our patients to get home quickly, from narcotics to anti-inflammatories to anti-nausea medications to nerve medications, things that are going to help you stay comfortable. And we approach pain from a multimodal standpoint. So we're not just giving you narcotics, but we're actually trying to control pain through multiple different pathways, from, again, Tylenol, meloxicam, and anti-inflammatory. Some narcotic is important, but we get patients off that pretty quickly. And with the other medications, patients are doing fairly well in a matter of just 2 to 3 weeks as far as getting off of some of the heavier meds. Patients overall still unfortunately do find the first 6 or 8 weeks as being fairly intense. But the good news is that by 6 or 8 weeks out, we expect our patients to be about 80, even 90% recovered. That's much faster than it used to be, where it could take 3 to 6 months before you got to 80 or 90% recovered. The last 10 to 20% of your recovery is all about focusing on your long-term goals, reintroducing your athletics, focusing on getting back to sports. And that can take up to a year to kind of dial in some of those things. But the bulk of your recovery is going to be behind you once you get to that 2-month mark. And so with our outpatient rapid recovery total joint program, again, both total hip and total and partial knee replacements, we're using anterior total hips with computer navigation or rapid recovery protocols. This is covered by all insurance carriers. And again, over 90% of our patients are safely discharging home within 24 hours. And actually, it's more like 6 or 8 hours these days. Total knee replacements are very similar, minimally invasive technique, robotic assisted, customized implants, personalized implants, rapid recovery. And again, just like our hip patients, we're seeing them discharge within 6 or 8 hours after surgery, and over 90% are leaving within 24 hours, which is still considered outpatient. So the reason why this is important is because COVID occurred in 2020. And as a lot of us have seen nationally, COVID has created a lot of healthcare crises around us. It seems to be somewhat interesting because I came into this practice in 2015, and we started kind of dabbling with outpatient total joints and kind of got our act together before we had to make decisions. But when COVID happened and the hospitals started shutting down, we had these safety protocols in place, and we're able to safely pivot and transition to do most of our elective patients at our outpatient surgery center, where the risk of COVID and exposure is excessively low. So that's really good. And the nice thing about, honestly, COVID too, is it helped get our insurance carriers on board with all of this as well. So even Medicare allows us to do outpatient total joints. We also know that, again, 90 to 95% of our patients are safely discharging home 6 or 8 hours after their surgery. And outpatient total joints at the surgery center are a more cost-effective and safe choice for the right patient. And so keep that in mind, that it actually is less cost burdensome on the healthcare system. So it is a good alternative. So again, in order to kind of, kind of help us understand where we are with our total joints, let's kind of review a couple cases. This is a total hip case that we did at our surgery center. This is a 64-year-old female. What you're looking at in the top right corner of your screen is what we call an anterior posterior pelvis x-ray. So we're seeing the pelvis, and we're seeing both the right and the left hip. Keep in mind that as you are looking at these x-rays, you're looking at them as if you're looking at the person head on, looking at their face. And so the left side is going to be on your right side. Okay, so the left side is the side that shows a lot of bony destruction in the top right corner of your screen. And with that being said, she had severe left hip osteoarthritis, a lot of bony destruction, cystic changes, and she was functionally debilitated with this hip. She couldn't even walk with it. We did an outpatient total hip replacement, direct anterior approach. We used our computer navigation systems, and she discharged home 6 hours after her surgery. At 6 weeks post-op, she was already reporting a 90% recovery. She was walking unassisted. She was working on her strength and balance and coordination, and she was off of all the medications we gave her. And in fact, she was so happy. She was very emotional in clinic and just couldn't believe the new lease on life that she was given. She was so thankful. As we look at these new hip implants, this is what we use actually. So DePuy Synthes is our total hip carrier or total hip company. They're a Johnson & Johnson based company, but their hip replacement stem, I think, is one of their best, one of the best out there. And their bearing, which is the ceramic head and the plastic liner, what we call a hard-on soft bearing, is the best option we have in 2021. As we know, total joint replacement surgery 15 years ago when I was in my residency kind of became got a bad rap with metal on metal hip replacements. We've all heard about this, I suspect, at this point, where hip recalls were happening, people were having more surgery because of bad implants, all these things, so on. And what we've learned as an orthopedic community is the metal on metal hip replacements and hip resurfacings are found to be too dangerous at this point in time. So we no longer use metal on metal hip replacements. What we did was we went back to the drawing board to Dr. Charnley's recommendations back in the 1960s about using a metal head on a plastic liner. And with that being said, we took it one step forward and we found that the ceramic heads that we use provide significant strength and minimal polyethylene wear with our newer polyethylene technologies. And so with that being said, it's a long convoluted story to say with our new ceramic heads and plastic liners, the wear patterns are very, very low, meaning that these hips have the potential of lasting a very, very long time. But as you can see, with all this technology, we're moving surgery away from an artistic surgery, because that's what total joint surgery is. It's really a soft tissue balancing surgery. We're moving away from an artistic surgery and turning it into more scientific. And this allows us to improve the accuracy of your joint replacement and improve your early rapid recovery and long-term success with additional decreased soft tissue trauma. And the nice thing about it is it allows me, to do a more reproducible total joint replacement. Historically, about 10% of hip replacement patients report some kind of dissatisfaction with chronic pain or leg length discrepancy or hip dislocations. All these things are really frustrating for patients when those occur. The good news is, with our newer technologies and techniques, we actually see that our patients at 1 year out are reporting a 98% chance of doing so well they forget they've had a hip replacement. There's a 1 or 2% chance where you could have some achiness with exercise or so on, but it's better than typically what you have. And then all the terrible things that we talk about, such as infections and failures and dislocations and bones breaking and all that stuff, all of that adds up to happen less than 1% of the time. So in reality, we spend a lot of time talking about the 1%, but you really have a 99% chance of doing very, very well and being very, very happy. If we look at how we do knees today as well, we've modernized the knee replacement. Outpatient total knee replacement surgery is here to stay, as well as the hip. And as you can see in this X-ray series, on the left side of your screen, we see a long leg X-ray of an arthritic knee joint, right knee. It's bone on bone. We have some subluxation of the joint where the bones are no longer lining up. And with that being said, this is a 69-year-old male with severe debilitating right knee pain. Was able to do a lot of activities, but just became more and more uncomfortable with this. He trialed a lot of injections and physical therapy for a long time, and he finally just had enough with it. He was ready to move on. And that's typically what we hear with our patients as they start to kind of go down this pathway. I recommend people live with their joints as long as they can, but at some point in time, you're going to come to a decision on your own that something else needs to be done. And when you get to that point, that's when you contact Dr. Beim or myself. But with this patient, we move forward with a same-day outpatient robotic-assisted right total knee arthroplasty, minimally invasive. And what we see in the middle X-ray is that long leg X-ray where we did a total knee replacement. And on the other two views, we see a lateral view and a patellofemoral view. So with the kneecap, remember, a knee joint is actually made up of 3 different compartments: the medial, the inner side of the femoral and tibial compartment, the lateral side or the outside, but also what we call the patellofemoral compartment, how the kneecap tracks along the anterior femur. And with that being said, we typically resurface all the parts, specifically when they're very arthritic. And so with that being said, we did a robotics-assisted total knee replacement. He discharged home about 10 hours after surgery. At 6 weeks post-op, he was reporting an 80% recovery. His knee range of motion was normal. He was walking normal unassisted, and he was working on strength, balance, and coordination as long-term goals of getting back to skiing. And one of the fun things about living in the mountains with our patients is that we get to do things with our patients. And I was actually able to ski with this gentleman at 6 months after surgery, and he was very, very happy. The other thing that we can offer is partial knee replacements. Now, we see more total knee candidates, meaning more patients with the knee completely arthritic. And we see probably 10% of our patients are candidates for partial knee replacements. There are pros and cons, and there's right decisions and not right decisions to have either or. And my job is to help work with you if I feel you're a candidate for more of a joint preserving partial knee replacement, to offer that to you. But it's a conversation we have together. But this is a 37-year-old male. He's a ski racer, lots of ski trauma to the knee, prior ACL reconstruction. Just kind of had worsening medial sided left knee pain. I apologize, I don't have a preoperative X-ray. But when you're 37 years old and you're bone on bone on the inside aspect of your knee, it's very, very frustrating. And with that being said, he wants to get back to ski racing. And so in order to try and salvage someone's knee, we can talk about doing osteotomies where we correct their alignment through bony corrections and so on. But really what this 37-year-old male needed was a partial knee replacement. And so we went forward and I performed a partial knee replacement. This gentleman I just did about 2 weeks ago. And he was able to go home right after surgery, and we just saw him at his 2-week visit, and he's doing really, really well. So we have options to do more joint preserving knee replacements. But again, it's not necessarily an option for everyone, but if you are a candidate for it, I'll let you know. So overall, the newer technologies that we're seeing in knee replacement and hip replacement surgery include technology, they include implants. And what this allows us to do is we're moving away from the art of surgery and we're turning it into more scientific technique. So again, this allows us to minimize soft tissue trauma. It makes the surgery more reproducible case to case. With knee replacement surgeries in general, historically and nationally, we see that about 20% of patients are reporting some kind of dissatisfaction with a knee replacement, whether it's most commonly it's some kind of chronic pain. Other things like stiffness can be an issue as well. But with all this technology, we're seeing that 20% of patients with lingering pain can be much smaller. And in our practice, we're seeing our patients report a 95% satisfaction rate at 1 year out. They probably have a 4 or 5% chance of doing good with the knee replacement. Maybe it does ache a little bit with exercise or athletics. Maybe it swells a little bit longer or more than you want it to. Or maybe it's just a little bit stiffer than you want it to be. But typically it's still better than what you have before you have surgery. And then again, all the scary, terrible things that I tell you during, before surgery, the good news is all those things happen less than 1% of the time. So very, very low that something unfortunate happens. There are newer technologies from our Zimmer Biomet ROSA robot, conformist custom-made implants. And my job, and Dr. Beim's job, is to sift through all this stuff so we can provide you with the best options we have today. That's just a picture of me getting ready to perform surgery. So last few questions. Dr. Beim and I are very, very excited about offering total joint replacement surgery to our Gunnison community. And so the questions are really, when should you consider joint replacement surgery? Well, it's really a complex decision between you and your surgeon. You want to try and exhaust all the non-operative treatments first. You want to, but typically your body will let you know when it's time to consider this. And that's where I come in and Dr. Beim comes in, and we are here to help you get where you want to go. So the other question we often hear is how or what kind of activities can you get back to doing after joint replacements? Well, what we do know is with our newer technologies, our newer implants, patients are able to get back to more reproducible, wonderful quality of life. So with that being said, once you heal this up, if you were able to do something before surgery, my goal is to get you back to doing that after surgery. I'm not sure I would recommend you learn how to run ultra marathons after your knee replacement. But if you're a big time skier and you're a big time golfer and you're a big time mountain biker and cyclist and all these other things, we want you to get back to that. And a lot of patients will. While any activity is safe, we still do encourage some lower impact athletics. I think the higher impact athletics historically have gotten knee and hip replacement patients into trouble. But again, with our newer technologies, that's less of an issue. But we still recommend avoid long distance running for exercise or aggressive court sports, specifically where you're cutting aggressively. And that can cause wear and tear arthritis. Remember, these are, not wear and tear arthritis, but these can cause wear and tear issues with the metal and plastic. And with that being said, think of a joint replacement like the brake pads on your car. The harder you push it, the harder you drive it, the faster it could wear out and the faster you may need new parts. And so with that being said, once you get a joint replacement, heal up, live your life, enjoy it. But just keep in mind that the harder you push it, the faster it could wear out over time. So with Dr. Beim's vision and with a lot of collaboration, we're excited to bring our world-class orthopedic care closer to home. And with that being said, Dr. Beim and I are working closely in order to build our joints program in the Gunnison Valley, wanting to provide this care to Crested View, Gunnison, the surrounding communities, in order to allow us to provide you localized care so you don't have to travel over the pass anymore. We want you to work, but unfortunately we have some work to do still, and that's where we are still working on our infrastructure. Right now, Alpine Surgery Center is nicely dialed in to do total knee replacements and partial knee replacements. So that's what we're going to focus our energies on right now. Our future goal is to eventually provide anterior total hips, but that's another level of complexity that we have to kind of work towards. And so right now we're providing knee replacement surgery services. Both Dr. Beim and I and our new partner, Dr. Lindsay, can do all the primary total joints at the Alpine Surgery Center. And more complex cases and potentially revision cases do still need to travel to the hospital, but we will help you figure that out and navigate that with you. Other things we're working on a lot for me personally is transportation. How am I getting down to Gunnison reliably? Whether, is weather going to affect that and all these other things? Where would I, what kind of housing options we have? Unfortunately, insurance is part of this discussion, and we are working with your insurance carriers in order to make sure we can provide this quality of care locally as well. We are well into those conversations, and hopefully we'll have a lot of answers very, very soon. And again, we're working with industry. We want to make sure this is a cost-effective approach. Implant companies are very, very good, but just like anything, they are interested in the cost of their implants, and so are we, and we want to minimize the cost as much as we can. So those are the negotiations we're doing right now in order to help bring the service line to your communities. But again, the things that require, the surgeries that require higher level of care are the revisions, infections, and some complex and conversion cases where we go from prior surgeries to total knee replacements or total hip replacements. Sometimes those still need to be done at the hospital. So overall, total joint replacement surgery is better than ever. Patients are getting back to an awesome quality of life faster and sooner with our rapid recovery protocols and our anesthetics and our physical therapy and our pain modalities. The newer techniques and technologies that we're using and that we're bringing to the Gunnison Valley allow us to provide minimally invasive joint replacement surgeries. We're improving and customizing your joint replacement, and we're moving, again, away from artistic surgery to more of a scientific approach that allows us to improve your outcome. And remember, orthopedic surgery is a team approach. This is a team sport, and with all of us working together, Dr. Beim and myself and our partners and you as our patients and our community, we take care of you to meet your needs. And keep in mind that Dr. Beim has a wonderful history of taking care of her patients locally. We want to honor that. We want to keep you locally. And we can take care of your needs from the preoperative, non-operative management to the post-surgical management. Even if I'm traveling back and forth to do these surgeries, Dr. Beim, Dr. Lindsay, and myself are motivated to prevent or help you minimize how much traveling you have to do. And again, our overall goal is to bring world-class total joint care closer to home in Gunnison. So anyway, that's really it. It's been a pleasure to talk to all of you. Again, I'm Dr. Nathan Cafferky, and I wanted to say thank you to Dr. Beim for all of her vision and all of her expertise and all the years of providing excellent care for our communities there locally in the Gunnison Valley. All right, so I guess we can start taking questions here. I got to figure out how to do this.
Hey, Dr. Cafferky. So if you go to the bottom of your screen, it looks like all of our questions right now are in that Q&A box. So if you see the Q&A with the 6 notifications there. Yeah,
perfect.
There you go.
Okay, I pulled some up. So I'm going to try and go through these. Well, there's quite a few. So I'm going to try and go through these. Just give me a second here. Okay, so all right, so I'm going to start off with this one from one of our visitors here. I'm going to just use your first name if that's okay. But Tim, it's good to talk to you. Thank you for the question. I'm just going to read this question out loud if that's okay with you. You did some research with Dr. Harlan Amstutz, a legend who did some value propositions, getting patients back to full activity. You're having some issues with your knee, and Dr. Cunningham said you had bone on bone. Are there similar get back to full activity options for knees? Well, again, with bone on bone arthritis, without seeing x-rays, I'd have to really kind of evaluate where you are with this. Again, once we get to bone on bone, the options really are either live with it with the non-operative care injections and anti-inflammatories, or consider some kind of joint replacement surgery, whether that's a partial knee or a total knee. Unfortunately, once we get bone on bone knee arthroscopy, becomes less reliable. And so most people at that point with what we call degenerative knee scopes are not seeing long-term relief with that. And so oftentimes we recommend, depending on the status of your arthritis, to either consider injections or surgery. Mike, it's also good to talk to you. What type of robotics are being used for replacement technologies? Well, there are a couple different options available to you, again, from the Mako robot to the Rosa robot, which is the one I use, to Velis, which is by DePuy, to Navio by Smith & Nephew. So there are a number of different robotic solutions available to you. My job is to sift through all these technologies and find the one that works best in my hands so that I can reproduce your surgery and your outcomes from case to case to case. And so there are a number of different robotic platforms available to you. I use the Rosa for my knees, and I use the Velis navigation system for the hips, and that seems to be working very, very well for our patients. Jennifer, nice to also talk to you. How do you address leg lengths with total joints? Well, that's actually a multi-step question. And so typically what we do is we check some x-rays preoperatively, and then intraoperatively, we actually evaluate your leg lengths through a physical examination. And we also use a navigation system, that Velis navigation robotic system. And with that being said, we were able to evaluate your other hip and the one we're operating on with our x-rays and our navigation system. We're able to restore balance to your soft tissue structures by giving you more offset, which is the distance lateral from your center, your core, and then additional length. And so our job is to balance that offset and leg length in such a way that it provides you with a very happy, healthy, stable hip joint. And again, the last thing we do once we use all this technology is we do just a regular physical exam. We get our hands on your knees, we get our hands on your feet, and we double check and make sure everything is balanced appropriately. And so that's how we do it. We use a lot of technology, but we also go back to our training and our basics. And we see that the outliers of patients with significant discrepancies are actually very, very low. Let me see, what other questions? Dr. Beim, do you have any other questions or?
I just wanted to add a couple things. That was an amazing talk, Dr. Cafferky. Thank you so much. As far as conservative measures go, when it comes to injections, I've found that steroids don't usually last very long. They might help. They usually kick in a couple days, and if they work, they might last a few weeks, a few months. There are other injection options. I haven't had great success with the hyaluronic acid. Some people swear by it, but most people don't get a great advantage from it. I've had some really good results with platelets. I don't know if you guys have heard of platelet-rich plasma or autologous platelets injections. So basically, you take blood, you spin it down in a centrifuge, and you get this little platelet rich plasma layer, and you inject it back into the joint. And 5 years ago or so, there wasn't a ton of literature, and it was really kind of sketchy. But now there's some great literature coming out that shows that it can help arthritic joints. It doesn't regrow cartilage. It doesn't cure arthritis, like Dr. Cafferky said. Nothing cures it, but you can get a lot of relief. And personally, I had great experience with it for about 3.5 years. I put my knee replacement off for 3.5 years, and then it just stopped working. So Dr. Cafferky did my total knee, as I mentioned earlier, and I was home, I think, in 3 hours after my surgery, and I was back to work in like 10 days. So I think I went back to work a little sooner than he wanted me to, but I kind of had to, and I did great. And when he talks about moving early helps, it really does. And I've done fantastic. I'm 7 weeks out today, and I don't want to go skiing, but I'll wait. He said to wait 3 months, so I'll wait. But it's just a remarkable how well I feel. But getting back to the injections, I have about 85-90% success, at least temporary, with my patients with the platelet injections, and it doesn't damage the joints, so you can repeat it if they work. The only problem with the platelets is the expense. Unfortunately, the insurance companies haven't been too kind for that technology yet, so it is an expense, but it is another option before doing surgery. And then another thing I wanted to add, in addition to weight loss and diet, Dr. Cafferky's right. If you're 10 pounds overweight, that's 30 to 40 pounds extra on your knee with walking. And around here, with all of our hikers and people who love to go downhill a lot, that can be up to 8 times of your body weight in the knee. So if you lose 20 pounds, it's 160 pounds off your knee going downhill. So weight loss is really a good strategy to try to avoid surgery as well. And then some studies have shown that people with high diets with high in sugar can cause inflammation in joints as well. So sometimes cutting out the sugars not only helps you lose weight, but it can also reduce inflammatory responses in the joints. So I love treating people conservatively as long as I can. And we don't treat x-rays. The x-ray can look awful, and I've got patients who have almost no pain. And then you have patients with not so bad x-rays and they can't function and their quality of life is awful despite all the conservative measures. So every patient's different, and we're always very excited to talk to you guys about conservative measures and avoid surgery when you can. But when it gets to the point where your quality of life is suffering, don't be afraid of the surgery. The risks are so low in Dr. Cafferky's hands. It's amazing. And the outcomes are amazing. And I can say that myself. Again, I've just gone through it. So I just wanted to add those little tidbits.
Yeah, thank you, Dr. Beim. I definitely agree with everything you said. The alternative injections available to you, again, beyond steroid and visco supplementation, the PRP, the biologics, those are options. Those are going to be potentially expensive, but some patients do respond to that, and some patients want to pursue that. And so that's always an option. And again, I can't stress to you enough that we want to treat you the way you want to be treated. And we don't really just treat the x-rays. So again, I see patients, like Dr. Beim said, whose knees and hips, they look terrible on x-ray. I'm like, how have you lived with this knee or hip this long? And patients like, oh, it's not that bad. And at that point, we keep treating that patient without surgery. But again, we see patients who come in and they have a lot of pain and their x-rays aren't terrible yet. And we are going to continue to treat you the way you want to be treated. But at the end of the day, our goal is to make sure that we maximize all options available to you before we commit to surgery. A couple more questions. So Tim, good to hear from you again. It sounds like you're a big time skier. What can you get back to? The answers are anything you want. If you were able to ski double black diamonds, Corbett's and Jackson Hole, I want you to do that. And have a number of patients who work on the race crew for Birds of Prey. That's a very steep run for those of you who haven't skied Birds of Prey, but definitely are skiing that on their joint replacements, seem to be doing quite well. So it's not going to be an overnight return back to aggressive double black diamond skiing, but that is something I want you to work towards over that first year, and a lot of patients get back to that. Anonymous, nice to see you. Sounds like we met before. One question you brought up is, is it better to have a knee replacement at a younger age or wait until you're older? I think you have to understand that historically, knee replacement surgery and joint replacement surgery had a lifespan that was unfortunately shorter than ours. And with that being said, we used to push people to get as old as they could before they wanted their joint replacements. Because historically, a joint replacement lasted 10 to 15 years was very, very good. And so that what we call transitional age, where patients could historically start pursuing joint replacements, was kind of late 60s, early 70s. With our newer technologies, we are seeing us be able to safely do joint replacement surgeries on a much younger age group, patients in their 50s, and occasionally I still have to do it for patients in their 40s because, again, the hand they were dealt. So with that being said, I always would recommend you wait as long as you can, kind of get as old as you can before you commit to it, because even if a joint replacement lasts 25 years, every time we have to do a revision surgery, it's potentially a little bit more challenging, a little bit more complex, and the return to lifestyle qualities can be a little bit more unpredictable depending on what has to be done at that revision. So, but the good news is with the bearing technologies that we have and the implants we use, there is a very good opportunity that a 50-year-old who gets a knee replacement today would have a very wonderful quality of life well into their 70s, and potentially might need a revision, but also might not. Again, we're looking at our long-term data. A lot of this is bench research. A lot of this is still being investigated, but what we're seeing with the newer bearings is they just don't wear out the way they used to. And so there's a lot of opportunity. They can last a very long time. Victoria, good to hear from you. Are thumb joint replacements an option? Actually, they are. And with that being said, I have a couple hand partners that specialize in that, Dr. Dorf and Dr. Joseph. They are currently in Eagle and Summit County. We are actively working on trying to get them down to Gunnison as well. So that is something that we provide at Vail-Summit Orthopaedics and neurosurgery as well. Again, Lisa, also good to talk to you. And I thank you for the question. How long will a total knee replacement last with an active lifestyle? Again, there's a very good chance, probably an 80 to 85% chance a knee replacement with an active lifestyle will last 20 to 25 years. But with anything, the harder you push it, the faster it could fail. And so typically, if you can avoid the higher impact sports, running, for instance, now, if you're having to run to catch the bus or run away from a bear, go for it, do what you got to do. But if you're running for exercise, I would probably say time to get on the bike and go for a bike ride. I'd rather you bike from here to Mexico than run from here to 15 miles down the road. So keep that in mind. Another question from Lisa, are bilateral replacements common? If so, how common is it to use a different replacement, total or partial, in each knee in bilateral replacements? So we see a lot of patients with symmetry where both joints are worn out, but we see a lot of patients where only one joint is worn out. And with that being said, we can offer specific patients bilateral total joint and bilateral total hip replacements. I would say that that's not as common because doing them both at the same time is actually much more intense for everyone involved. Myself, the patient, the recovery takes usually longer. But we want to make sure everyone's doing well. So I'm happy to have honest conversations with you based on what your needs are. And I'm also looking at your health status, your age, your number of different factors, how healthy your heart is and your lungs are, in order to make sure that you are a candidate for both your joints being replaced at the same time. Oftentimes what I recommend is that as we go through this, it actually is a little bit nicer for you as the patient to have each one done separately under different anesthetics. And the reason why is because if you do one knee first, you give that about a month to recover. That first knee is overall kind of on a cruise control situation, and then we can do the next knee pretty quick. And that way you really only have one functional recovery. If we do them both at the same time or spread both knees out too far apart, it's almost like your recovery can take twice as long. And so with that being said, I look at all options. I have patients who, they're airline pilots and they can't take so much time off work. They have to get them both done so they can get back to, their FAA clearance and get back to flying, and they have to have both knees done simultaneously. And so we'll do that for, patients who are really in tight situations. But if we can avoid doing them both at the same time, it's a little bit more comfortable, actually, and a little bit more straightforward as far as recovery goes. As far as doing one knee, one total knee, and one partial knee, sure. Whatever you need to get back on the road to recovery and get back out there is the right choice. And those are things that we look at together in order to make sure we're meeting your needs. Another question here. Sorry, let me get caught up here. I got to kind of read through some of these. All right, so SC, nice to talk to you, or thank you for the question. If you're a candidate for a partial knee at age 57, how far down the road, down the road you need a conversion to a total knee replacement, how successful can that be? What are the options, or what are the risks of opting for a partial knee over a total? So, well, Dr. Beim can probably talk about this, but with that being said, partial knees are considered joint preserving type surgeries. We're only replacing one part of the knee itself. And with that being said, it actually typically isn't that the partial knee fails over time, it's the rest of the knee will catch up. And so patients with inflammatory arthritis like rheumatoid or psoriatic arthritis, they're really not candidates for partial knee replacement, unfortunately. Patients with isolated post-traumatic or osteoarthritis can be candidates for partial knee replacements. The nice thing about a partial knee replacement is it does feel a little bit more natural, a little less mechanical. But over time, you may ultimately need a conversion to a total knee. The good news is that it really doesn't burn any bridges to go from a partial knee to a total knee. The surgery takes me a little bit longer, but the outcomes are functionally very similar. Sometimes patients may have a little bit more scar tissue when we go back in there to do the conversion to total knee surgery. So we have to do a little bit more scar tissue cleanup. That can sometimes result in a little bit more scar tissue developing after surgery. So we have to work very, very hard with physical therapy to get your knee motion back. But I'd like to actually ask Dr. Beim if she's comfortable telling us a little bit about her experience, as this is exactly what she went through.
Yeah. So I originally, I had arthritis in 2 compartments out of 3, but my patellofemoral one in the front was by far the worst. So I had a partial knee replacement, and it was great. I couldn't get out of a chair without using my arms before surgery. I couldn't ski, I couldn't hike. It was miserable. So I had that surgery and it worked quite well. But a few years later, my lateral compartment on the outside started breaking down and catching up with the arthritis for the first one. And again, I was able to stretch it out another few years with the platelet injections, and I was able to ski and do everything. And then last April, I had a ski accident and it threw me over the edge. I couldn't come back. I tried. So I had the revision from the partial of the patellofemoral joint to a total, and fantastic. I can't tell you enough how satisfied I am. All that pre-op pain is gone. I'm still dealing with a little stiffness. I'm still recovering. I'm only 7 weeks, but all that pre-op pain is gone. And I thought for me, it was worth stretching it out an extra 8 years before getting a total, because it did feel more naturally. I can tell with my total knee, again, I'm not fully recovered, but it does feel a little bit more mechanical. With the partial knee, it felt pretty normal. And I suspect once I get all my strength back, my total knee will feel pretty close to normal as well. But for me, it was a good decision, and I'm pretty young still. So to have a total 8 years ago or so, when I was in my, early 40s, it was worth it. Absolutely. Yeah.
Great. And so again, the decision to have a partial or a total knee is, again, it's a multi-step conversation between you and your desires and your wishes and what we see as being the safest option for you. We're going to try and match those up so we end up at a good result. But at the end of the day, it's a discussion between all of us. And if that's something we're thinking about, we really recommend an appointment so we can get to know you both on the X-ray side and do a physical exam and try to come up with a surgical option that makes the most sense for us today. We have to live today and live our lives as best we can today with the information we have. And then we kind of have to roll with the punches down the road, if any come up. But the good news is, with everything I do, from partial knees to total knees to conversions to revisions to infections to fractures to you name it, this is my practice. This is what I do. And so with Dr. Beim's leadership and with my experience, we definitely can get you where you need to go with this. So another question from Robert. It's, oh, good to hear from you, Robert. It's been a while since I've seen you. Sorry to hear about some other issues that have developed. The question is mostly, what can you do about your knee now? I'd love to actually have you come back to clinic so I can kind of get to see your knee a little bit more now that some of your other issues have been addressed. But yeah, let's talk, Robert. Come in and see me, okay? I'd love to see you in clinic. Couple more questions.
Dr. Cafferky, if you're willing, one of my patients is asking a question. She's a dear friend of mine as well, Gail. Would you be willing to answer her question? Hi, Gail.
Of course. Hi, Gail. Where's the question? I'm sorry, I don't quite see the question here.
Keep going, Gail.
Hey, just to chime in really quick, guys. I'm gonna mark all the previous questions that you answered, Dr. Cafferky has answered, so that you don't trip up over them when you're scrolling back through the Q&A log. Is that okay?
Of course, thank you.
Cool.
And again, our goal is to try to get all these questions answered. We may run out of time, unfortunately. So keep in mind, we want to hear from all of you. And if we don't get to your question, or if you walk away from this with more questions, please reach out to us. We love to see you in our clinics. We love to, get some x-rays. We love to kind of get to know you and take care of you. So again, if we unfortunately don't get to all the questions tonight, please feel free to reach out to us. On the screen in front of you, you see a lot of ways to get a hold of us. So please don't hesitate. Okay, Gail, good to hear from you. what are advantages and disadvantages of using the robotic technique? Also, how do you treat the patella in a total knee replacement? Does Medicare still require surgery to be done in a hospital? And now with COVID flaring, is it wise to wait? Wow, good questions, Gail. Okay, so here we go. So the gold standard for knee replacement surgery is conventional instrumentation. Okay, so that's our benchmark. That's what we base all of our additional technologies off of. So traditional total knee replacements are still predominantly used everywhere in the world. Here in the United States, around the world, conventional instrumentation is still widely used and much more adopted than additional technologies. So what robotics really brings to the table again is that we're turning more of a soft tissue artistic balancing surgery into more of a scientific surgery. The studies behind some of these ideas are not as black and white as we might like, but we can see that in our patients with total knee replacements, whether they've used robotics or not, do very well. We are doing a lot of active research right now, and I've published about 6 papers in peer-reviewed journals over the last 6 years on our in the last year on our outcomes data. And we are seeing some pretty tremendous results. Now, the question is it going to be different as a group, as a national group? There is a registry called the American Joint Replacement Registry that we actually look at. So everyone who has a joint replacement in the United States is a part of this registry. It's de-identified. We don't know who you are, but we know someone had a knee replacement done in this day and this year. And we can track that, whether that was done with robotics or navigation or conventional instrumentation. And every time you see us in clinic, we track that data to see how you're doing. And we compare that to national benchmarks. And that allows us to do research on how we take care of our patients to see if what we're doing is safe, see if what we're doing is better, see if what we're doing is worse. And so with that being said, our goal is to provide you with the best quality of care that we can. I think robotics is definitely a part of our lives now in surgery. I think conventional instrumentation and conventional total knees are also the gold standard. My goal is to take care of you the best way I can. In our Gunnison Center, we don't have robotic technology there, but to Dr. Beim's point, and by the way, Dr. Beim was one of our first patients at her surgery center in Gunnison. And we did a conventional total knee replacement, converting her from a partial knee to a total knee, and she's really done incredibly well. And so with that being said, you can do great with both options. The most important thing is that the surgeon that's taking care of you, whether myself or another surgeon, feels confident and comfortable with the way they are doing the joint replacement. Another thing, how do I treat the patella in a total knee replacement? Well, boy, this is actually a very complex discussion. So in my practice, I follow a lot of the American data. And with that being said, I resurface most of the, probably 99.9% of patellas. What does that mean? Is the bone that you feel in the front of your knee right now is the bone you will feel after the surgery. But what I do is underneath the patella is I resurface it and put a little plastic button. And my goal is to take away any kind of pain generator that I can. And bone rubbing on metal can also cause pain. And so with that being said, I resurface the patella every time I do a knee replacement. There's also another school of thought, and that's based off the European data. And the European data see knee replacements as isolated compartments. And with that being said, in the European data, historically, they have not resurfaced the patella. So they leave the patella alone, and the patella rubs on the metal. We also know with the European data that patients also can do very, very well with that. And a lot of patients running around with native patellas in the total knee are doing great, skiing and biking and hiking. But one of the issues that we see is patients who have unresurfaced patellas, their native patella, they are at a slightly higher risk for needing additional surgery to go in and resurface the patella down the road. And so with that being said, I do consider that for my younger patients who are very, very young, young 40-year-olds or 30-year-olds that have to get these surgeries because of trauma and so on. They're the patients in my practice I probably don't resurface the patella because they're probably going to need more surgery in the future. And I want to try and keep as much bone around in the future as I can so I have more foundation to work off. As we get older, we just resurface it because, again, the patella compartment, once it's resurfaced, rarely fails. and rarely needs revisions. It's most of the time the femur and the tibia. And so with that being said, when we get older, we just want to maximize pain relief and function as much as we can. So in my practice, I resurface the patellas. So that's a long, convoluted way of saying I resurface patellas unless you're on the younger, like really young. The other question you have is, does Medicare still require surgery to be done in the hospital? And now with COVID flaring, is it wise to wait? Medicare actually kind of surprised all of us. When COVID happened, Medicare allowed us to do all of our total joints, hips and knees at our outpatient surgery center. In fact, before COVID, Medicare was allowing total knees to be done at the surgery center, and they took it off the inpatient only list years before COVID happened. Hips were a different story. When COVID happened and the hospitals were shutting down, Medicare actually followed the trends nationally, and they took hip replacements off the inpatient only list and allowed us to do hip replacements and knee replacements at the surgery center. Recently, as in like last week, Medicare has decided to put hip replacements back on the inpatient only list. And so probably starting in 2022, we're going to have to do Medicare hips back at the hospital. And as far as waiting for joint replacement surgery now or in the future after COVID comes and goes, that's a personal decision. We aren't seeing any evidence of increased risk of infections or poor outcomes with COVID and vaccines at this time around what we call the perioperative period for someone who's had a total joint replacement. But if that's a concern for you, then that's something to consider. And I want to work with you to make sure we have a thoughtful way of taking care of you with this crazy world around us and this pandemic. And if that means waiting a little bit longer, we'll treat you non-operatively until you feel comfortable to have it done. As far as waiting though, again, that's really a personal decision based on all the information and knowledge we have at this moment in time. Gail, I hope that answered your questions. Okay. Glenda, good to hear from you. A knee replacement safe for healthy patients at age 94. It can be, actually. And so with that being said, I had a 92-year-old patient who came in a few years ago who was really frustrated with his knee because he went heli skiing in Canada and he couldn't ski as much vertical feet as he wanted to. And so he came in, he looked about 15 years younger than I honestly, I had to ask him, I was like, so are you really 92? And he goes, yes. And so we treated him with a total knee replacement and ended up doing well and got back out there and skied. And so the answer with age is that we don't really care about the number, we care about your health. We see patients in all aspects of life. Some patients remain in good health and good physical shape well into their 90s. And unfortunately, life happens at any time. I've had patients who unfortunately had a big medical issue while I was taking care of their non-operative needs, and they had a stroke and they were no longer surgical candidates. So we could not do their knee replacement. So unfortunately, there are reasons why we would no longer be surgical candidates. But as long as we stay in good health, and as long as we're all on the same page, I'm happy to do a knee replacement really at any age, as long as we have a safe plan for you. A couple other things. I'm going to kind of scroll back up as I missed a couple questions here. Let's see. Kind of answered one of those questions just now.
So I think you answered
I answered
Lynn's or Gail's. So I think above that, I don't think you'd answered those ones.
Yeah, so okay, so Jim, good talking to you. Thanks for the question. Very nice question, by the way. A steroid injection into my left knee did very little to nothing at all. But following that, a Synvisc injection had great relief. Can you discuss Synvisc? Well, that's actually our workflow. And so Synvisc is not as readily covered by insurance as it used to be. Okay, and the reason why is that we had a lot of data that came out about 10 years ago that brought visco supplementation or Synvisc into question, and the efficacy and the benefit and all that stuff. And so a lot of insurances have kind of stepped away from just default covering Synvisc injections for everyone the minute they come in the door. And so oftentimes we approach someone with new symptoms of pain and arthritis, specifically in their knee. Synvisc is really only FDA approved for the knee, by the way. And with that being said, we start with a steroid-based injection. That's covered by insurance. It's not a big deal to get a steroid injection from an insurance company. And so we start with that. And with that being said, our patients who respond well to steroid injections can get repeat steroid injections every 3 months or so if needed. Synvisc is different. So Synvisc is really a lubricant style injection. We call that hyaluronic acid. And with that being said, hyaluronic acid is part of the substance that helps makes up cartilage, helps makes up synovial fluid. It's kind of like putting, again, WD-40 in the joint. And with that being said, if you did not respond to a steroid-based injection, which it sounds like, Jim, that was your case, we then have additional ammunition to go to the insurance company and say, hey, Jim tried a steroid injection, it didn't work. We think he's going to benefit from trying a Synvisc injection. And that typically gives us more ammunition to ask for the insurance company to provide us with that authorization so that we can give you that Synvisc injection. The risk with any of these injections, though, is you try them and they don't help you. And that may represent that your body's just so, your knee is so arthritic that we may just have to talk about surgery. But again, I'm happy to do what you want me to do, and Dr. Beim's the same way. So I hope that answered your question. Lynn, can you speak to scar tissue development and knee replacements for those who develop a lot of scar tissue after surgery, how to prevent and how to deal with it several years after surgery? So this can be complex. The majority of patients will kind of cruise through their knee replacement with minimal scar tissue formation. And again, most patients by 2 months out are doing really well, about 80–90% recovered. Unfortunately, there are a handful of patients that are hyperscar formers. We call those keloids or hypertrophic scar formation. That can be very difficult. With that being said, the best way we can control for that is day 0, meaning we do surgery, we wake up, we instantly go to PT, we instantly start moving the knee. And occasionally, once in a while, someone just struggles because their body is healing faster than they can move their knees. They're scarring in faster than they can move their knee. If we get to those patients who are scar formers aggressively, and that's why we see patients back around 2 months out, because there's kind of this window where I can step in or Dr. Beim can step in and do what's called a manipulation. If that's the case and we get to that around 8 to 10 weeks after your knee replacement, we can go back to the OR, we can go back to sleep. We can do what's called a manipulation where we forcefully move your knee for you under anesthesia and tear up scar tissue and kind of get you back on track. Now, even more rare than that is that someone will go through the manipulation and still struggle. And if that's the case, then we're looking at doing more surgical intervention where we go back to the OR and we do like arthroscopic debridements and what's called lysis of adhesions, and we clean up scar tissue. And ultimately, if that doesn't work, then we're actually going back to the OR and doing open lysis of adhesions and revision surgeries. That's the last resort. There are some reasons why knees just don't move. That can be, again, biological with scar tissue, but sometimes mechanical. And so if there's a mechanical aspect to the knee that's preventing you from moving, then we typically recommend revision surgery sooner rather than later. But oftentimes it's a balancing act between letting your knee heal in such a way that you avoid infection, but not scar in so quickly that you can't move your knee. And oftentimes for majority of people, that's pretty straightforward, but once in a while it is a struggle. And we want to work with you to help you get where you need to go. Years after surgery, though, the one thing, Lynn, about your question, how do you deal with this several years after surgery? That's a very complex discussion, and it really kind of depends on why the knee is not moving. Sometimes that's an issue with the patella. Sometimes that's an issue with scar tissue. Sometimes that's an issue with implant malposition. And so part of my job is to try to work that up as best I can and try to find the reason why that problem is existing. Allergy issues, we know more about allergies and orthopedic implants today than we ever did before. Sometimes patients will have an allergy to metal, which, 5 years ago, we didn't really care about. Like, it just wasn't a topic of discussion. 10 years ago, we never even thought about it. Like, And so what we do know is that some patients with allergies to this stuff, to the implants, can have poor outcomes. And if that's the case, then oftentimes we're taking everything out and we're starting over. And part of our intake questionnaire is just to ask you, hey, do you have any allergies? That includes drug allergies, that includes metal allergies, that includes any kind of allergy that you can think of, hay fever, bees, environmental allergies. We want to know if there are any allergies you have. And unfortunately, even if we do everything right, once in a while, someone just develops a hypersensitivity allergy after the surgery. And so that's just the complex nature of our body. But at the end of the day, down the road, if we're still struggling with that knee, I need to figure out why it's not working so I can make it better. And the goal is that whenever I'm going in to do a revision, I want to make sure that I understand why it's not working so I can correct that for you surgically and prevent it from happening again. So if I can figure out the why, I can figure out the how, and that's what's most important. Okay, another few questions here. We have quite a few left. Okay, so Dr. Beim, are there any other topics we should talk about? Anything else that you want to mention here? I'm just kind of going through questions and making sure I'm answering them. So.
Dr. Beim, you are muted. Sorry.
There, can you hear me now?
Yes.
You're doing a fantastic job, Dr. Cafferky, and getting to everyone's questions like that. I just, while you're still reading through a few of the other questions here about technical issues from the knee replacements, I just want to reiterate how many ways we could try to treat people non-operatively, including if you do have one compartment that's arthritic and the rest is pretty good. Sometimes you can buy a couple years with an unloaded brace, for instance. So if you have a lot of disease on the medial side, the inside, and you're getting close to bone on bone, we can sometimes use a brace that unloads that area, especially in younger people. And that can, you can wear it skiing and hiking, and if you're on your feet all day at work, and that can be very helpful as well. So again, we have a lot of non-operative tricks to try to work with you until they all fail, and then you do the surgery. And there's no guarantee to any surgery. You can have a simple knee scope, and you could get a blood clot or an infection. I mean, these are all very, very, very small risks, but they're there, and that's why we try to do all the conservative approaches first before the surgery.
Exactly. Thank you, Dr. Beim, for that. So with Jerry, when you're doing a knee and you see other issues like tissue on associated tendons, what is your approach? I guess what we do is and this kind of Fred, I think this also answered, I'm sorry, not Fred, I'll get to you, but Anonymous, your other question about do we remove the cruciates? Do we keep one or two? What do we do with the ligaments? So I'm going to answer Jerry, your question, and Anonymous, your question in the same idea here. So with that being said, we can do knee replacements with what we call PCL or cruciate sacrificing or substituting knee replacements. That's basically where we take away your cruciate ligaments and we make up for that with the metal and plastic. That is a good option for a lot of patients with, again, history of rheumatoid arthritis, inflammatory arthropathies. Oftentimes we cannot rely on your cruciate ligaments to function because they just get so beat up from the inflammation and the systemic disease. For patients with osteoarthritis, we oftentimes try to keep, my personal preference is to keep the PCL, the posterior cruciate ligament, as much as we can. The MCL and the LCL, we also keep every time. And with that being said, we see those patients do very well. With post-traumatic surgeries, the keeping of the PCL is somewhat dependent on somewhat dependent on your prior trauma. The PCL can scar down even in the best situations, and it just is too tight and we can't keep it and we have to release it. And other times it's fine. And so my preference is to keep the posterior cruciate ligament with the implant. That way it maybe feels a little bit more natural, but that is a very active area of debate in joint replacement surgery. And but keep in mind, if we do a PCL sacrificing knee replacement, that also works very well and allows you to ski, golf, bike, hike, all that stuff. The other thing to keep in mind is that the ACL is really no longer needed with total knee replacement surgeries. ACL preserving knee replacements actually have come and gone twice in the history of knee replacement surgery. Back, I think, in the 60s, we tried to do knee replacement surgery with the ACL. They failed catastrophically because of their, a number of factors. The other is the ACL preserving knees that came into play, about 10 years ago. There was a lot of excitement that maybe our newer designs and newer techniques allowed us to keep both the ACL and the PCL. Unfortunately, those knees also failed. And so what we see is that the ACL really is functionally no longer needed with the knee replacement. We try to keep the PCL whenever possible, but whether you get the PCL preserving or PCL substituting knee replacement, both are excellent options. As far as looking at associated tendons, sometimes we have to do what's called tendon releases if they're too tight in certain areas in order to balance the knee. With our newer techniques, we do less soft tissue releases than ever before, and thus our pain scores are much better because we're doing less soft tissue trauma. But once in a while, someone has a tendon that's just kind of too tight and pulling the knee into more of a knock-knee alignment, like the IT band, for instance, and we have to release that. But overall, that's not as common. Fred, also on your question, are the x-rays and MRI from my treatment with Dr. Cunningham ample for you to make an initial assessment for replacement? The answer is yes. One of the benefits of working with my partners, like Dr. Beim or Dr. Cunningham or any of my partners, is that we intimately know each other. We're all friends, we work well together, we sit in board meetings together, we share patients together. And so I trust my partners to take very good care of our patients. And so if you've seen one of my partners and there's questions about knee replacement surgery, the answer is yes. I typically can review their documentation because I trust their exam, I know who they are, and I'm looking at their imaging studies. And oftentimes that's enough for me to get a good sense for where you are today. And so I can give you an idea of what we need to do for you. If there are any other questions about that, sometimes I do order additional studies, but most of the time when you're coming from my partners, it's pretty much already done for me. So that's kind of nice. But again, to Dr. Beam's point, we don't just treat the x-rays or the MRI, we actually treat you as a person, and we want to make sure that whatever decision we make for you meets your needs. Okay. Whew. Colleen, good to hear from you. How successful are second total joint replacements? So the revisions, I'm assuming, is what you need. The revisions are actually very successful as well. The biggest risk of the biggest risk with revisions is actually infection. So that's why if I see a patient who's struggling with, a knee that's not gone well, or a hip that's not gone well, or it's been 20 years since you've had it done, it just is kind of wearing out. At that point, I always make sure we're not missing an infection. Okay, that usually results from me drawing some blood in the clinic, maybe aspirating your knee joint. And that gives me a pretty clear understanding of whether we're dealing with infection. And the reason why is the way we treat infection is different than the way we treat a knee that just needs to be redone. If there's infection, we have a much different conversation. If there's no infection, then the redos are actually very straightforward. But the outcomes are somewhat dependent on what I have to do. If all we have to do is change out the plastic and the metal parts are intact and everything's good there, that's a very straightforward surgery. We call that a poly swap, and patients do really well. If we're dealing with situations where the implants are coming out, the metal is coming out, and we're starting over, that gets a little bit more difficult, but the recovery may be longer, but overall the outcomes can be very, very good. But again, the biggest issue with revisions is just infection. And that's why we always make sure we're not dealing with infection. And the longer the surgery takes, and revisions typically take longer, higher risk of infection. The studies typically say when surgeries take more than 2 hours, your rate of infection does go up. And revisions oftentimes take 2 to 3 hours just because of what we have to do. And so there's a slightly higher risk of infection with revisions. Okay, so David, what can you comment about bursal pain after hip replacement? So that's actually a very good question. So David, with that being said, we do know that the IT band and the abductor muscles around the buttock insert on the greater trochanter, which is if you push on your hip on the side of your hip, what you're pushing on is actually the greater trochanter. And that's the insertion point for the big buttock muscles that are strong and healthy, and they all kind of insert in one particular location. So a little bit of a design flaw, maybe, so to speak. But with that being said, a lot of force happens in that one area. And with irritation before surgery or even after surgery, that can lead to a process called bursitis. Bursitis is very annoying because it's oftentimes a chronic issue. And with that being said, we can kind of keep you active and keep you comfortable and keep this at bay with injections and physical therapy and so on. And injections, they stem from steroid to stem cell and everything in between. And so with that being said, that's oftentimes what we do for chronic bursitis. After a hip replacement, it's a little bit more difficult because with hip replacement surgeries, again, we are recreating your biomechanical forces of your hip by giving you leg length. So increasing your leg length and increasing your offset. And the offset is the lateralization from the hip center to that greater trochanter. And oftentimes we have to increase offset in order to make sure your hip doesn't come out of socket. But if we increase it just too much, even just a couple millimeters more, it can lead to a lot of tension on the muscles, and that can lead to bursitis. And so if you think of like the abductor muscles, the gluteus maximus and medius and minimus and those muscles around the buttock, if you think of those like a bow and arrow, if you draw the bow and arrow and you pull back on the bow and arrow, all of a sudden you have a lot of tension in the system, and then it's ready to fire. You have a lot of potential energy. And with that being said, the buttock muscles are the same way. As we tension the buttock muscles, if we over tension them with the hip replacement, it can lead to bursitis, and sometimes that can be very frustrating. If that's something you're struggling with, I'd be more than happy to see you to discuss options for that. Or if you know of someone, I'd be happy to take a look. Okay, let me see.
I think you got through them all.
I think that's pretty good. Okay. All right. So with that being said, I think we kind of answered the bulk of the questions, and kind of we're seeing some concepts that we've already reviewed. But with that being said, keep in mind that Dr. Beim and I and all of our partners at Vail-Summit Orthopaedics and Neurosurgery, whether here in Vail or Summit County or in Gunnison County or Gunnison Valley, Crested Butte, Telluride, anywhere, any of our locations, we're more than happy to see you for any of your orthopedic needs, whether it's joint replacements, sports related, spine related, foot and ankle, hand, whatever. We are here to take a look. So keep us posted. We're always happy to hear from you.
All right, thanks everyone. Do we have any more questions for either Dr. Cafferky or Dr. Beim? I think we're good. If you guys do have more questions, please feel free to reach out. You can just simply reply to the email that you got the confirmation from for this. It's vailsummitorthopedics@gmail.com. Pretty simple. I will send that in the chat as well. And just keep in mind that, you know, any ailment you have or any pain you're experiencing or any questions you have are always going to be best answered by coming into the clinic and meeting with one of our specialists. So thank you for your time tonight. We'll be hosting our next VSON Alpine webinar with Dr. Adam Lindsay in 2 weeks from now. So please head to our website or just make sure you're signed up for our email newsletter program to get information on that. If you would like to request some more individual info on that, please shoot an email to the email that you got this confirmation from, and I'll be happy to send that to you. Thanks so much for joining us, and we hope to see you in 2 weeks.
Thank you, everybody.
Thank you.